morning, everyone. I'm Rebecca Vickers with the Florida Alcohol and Drug Abuse Association. We will be getting started right at 10 o'clock this morning. Good morning, everyone. I am Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Mandatory Child Welfare Reporting, What Behavioral Health Professionals Need to Know with Kathryn Shea. This webinar is being made available through a collaboration with the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADA's website within 30 business days. To access the recording and PowerPoint, go to www.fada.org and then to our Resource Center and then on to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, your web browser will direct you to an evaluation form on FADA's website. You will first need to register or sign in to the account to complete your evaluation. Information you provide FADA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at midnight on Wednesday, December 15th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial credit. Kathryn Shea has worked with children with serious emotional and behavioral disorders, including fetal alcohol syndrome and drug effects, for over 40 years. Ms. Shea received numerous awards for her work in infant mental health, fetal alcohol syndrome, and child advocacy. She currently serves on the board of FASD United and is an independent consultant at the local, state, and national level. Ms. Shea served as president and CEO of the Florida Center of Early Childhood for 12 years and is the past president of the Florida Association for Infant Mental Health. She received her bachelor's degree in psychology and her master's degree in social work from the University of Kentucky. And now I'd love to welcome our presenter, Kathryn Shea. I will turn the presentation over to you.
Thank you, Rebecca. And good morning, everyone. I am delighted to be here with you this morning to present on this very important topic of mandatory child welfare reporting and what behavioral health professionals need to know. And I'll just start off by saying this material is a little dry, but I'm going to try to make it as exciting as possible because it is really important information for all of us as behavioral health professionals to know and to be, because we are going to be such a part of the plans of safe care for the infants exposed prenatally to substances and to alcohol. So just hang in there with me, and we will take about a 5-minute, I know that's not much of a break, but we will take a 5-minute break right at around 11 o'clock when there's a good breaking point in the presentation. Enough of a 5 minutes that you can just get up and stretch and maybe get something to drink, and then we will resume. And we will end exactly at noon, if not a little bit before. And as Rebecca said, please, if you have any questions as we go along or comments, please put them in the chat box. And I will be watching the chat. And I know Rebecca will be helping me watch the chat to make sure that if time permits, we can answer all of your questions and respond to your comments. So we are going to get started in our presentation. So, due to changes in the Child Abuse Prevention and Treatment Act, known as CAPTA, reauthorization of 2010, and PL 114 to 198, the Comprehensive Addiction and Recovery Act, known as CARA, of 2016, Title V, Section 503, healthcare providers, including behavioral healthcare providers, caring for prenatally substance-exposed infants are now required to notify Child Protective Services of the occurrence of such condition of such infants. And really, the impetus for changing these laws was due to the opioid epidemic, which we have been experiencing nationwide since starting around 2013. And the changes now include plans of safe care, and we're going to talk a lot about plans of safe care today, notifications versus reports, and family-centered approaches, which is the focus of this presentation. So our learning objectives today, we are going to learn, we are going to understand what is meant by plans of safe care for an infant and the family or caregiver as required by the Child Abuse Prevention and Treatment Act. We're going to explain the parameters for notification of Child Protective Services for infants who are identified as affected by substance use, withdrawal symptoms, or fetal alcohol spectrum disorders. And I'm especially happy to know and to have seen that in 2016, with the changes, fetal alcohol spectrum disorders is now included. Prior to that, it was not. And then our third objective is to develop family-centered plans of safe care that are responsive to the needs of a mother and her infant, and certainly the entire family, if the family is responsible for caring for the infant. I think I just went too far. So around our first objective, we're just going to review a little bit about CAPTA, sort of a legislative history. And this was the key federal legislation addressing child abuse and neglect is the Child Abuse Prevention and Treatment Act, known as CAPTA. Originally enacted on January the 31st, 1974. And this act has been amended several times and was last reauthorized on December 20th, 2010 by the CAPTA Reauthorization Act of 2010. It was amended in 2015, 2016, and 2018. And most recently, certain provisions of the act were amended on January 7th, 2019 by the Victims of Child Abuse, the Victims of Child Abuse Act Reauthorization Act of 2018. So CAPTA provides federal funding and guidance to states in support of prevention, assessment, investigation, prosecution, and treatment activities, and also provides grants to public agencies and nonprofit organizations, including Indian tribes and tribal organizations, for both demonstration programs and for projects. It additionally identifies the federal role in supporting research, evaluation, technical assistance, and data collection activities. And it also establishes the Office on Child Abuse and Neglect and establishes a national clearinghouse of information relating to child abuse and neglect. So CAPTA really has a great deal of responsibility at the federal level, which then comes down to the state levels, and it's up to the state to make sure that they're enacting all of the CAPTA rules and regulations. So to receive Child Abuse Prevention and Treatment Act, or CAPTA funds, states are required to ensure that they operate programs relating to child abuse and neglect that include the following. And in our state of Florida, that is the Department of Children and Families that has this primary responsibility. Policies and procedures, including appropriate referrals to child protection service systems and for other appropriate services to address the needs of infants born and identified as being affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or from FASD. So that includes a requirement that healthcare providers involved in the delivery of care of such infants notify the Child Protective Services system of the occurrence of such condition of these infants. And then the development of a plan of safe care for infants born and identified as being affected by substance abuse or withdrawal symptoms or FASD to really ensure the safety and well-being of such infants following his or her release from the care of the healthcare providers, including through addressing the health and substance use disorder treatment needs of the infants and affected families and caregivers. So the legal authority underlying all of this is the Child Abuse Prevention and Treatment Act, CAPTA, which we just talked about, and the Comprehensive Addiction and Recovery Act, CARA, of 2016, which made several changes to CAPTA. And it now expands exposure criteria beyond illegal substances to include alcohol and prescribed medications. It now requires that a plan of safe care address the needs of both the infant and the affected family or caregiver. It now requires the development of policies and procedures to address the needs of infants identified as being affected by substance use or withdrawal symptoms. And it requires healthcare providers involved in the delivery and care of substance-affected infants to notify the Child Protective Services system. And as we said before, this also includes behavioral health providers. So in 2018, the state of Florida Department of Children and Families issued CFOP 170-8 Plan of Safe Care for infants affected by prenatal substance use, with the purpose of providing guidance for incorporation of a plan of safe care into Florida's practice model. CFOP 170-8 was created to reflect federal requirements for responding to infants and their family who have been affected by prenatal substance use, and this went into effect on July the 15th, 2018. And I really encourage all of you to read CFOP, the CFOP. I have a link there that will take you directly to it because it really is very well written and does a very good job of explaining how we put this into effect. And I just want to note here that a plan of safe care is not the equivalent of a safety plan. And sometimes people get those very confused, but they are two entirely different things. A plan of safe care may identify child safety and risk issues within the family, but a safety plan is the only vehicle for implementing specific protective actions. A plan of safe care is intended to facilitate a holistic, multidisciplinary approach to responding to the needs of the entire family. And a plan of safe care is intended to be developed at the earliest point the mother's use or infant's exposure have been identified. So that means that the plan of safe care can actually be written and implemented prior to the delivery of the baby. This can happen while the mom is pregnant. And there's usually a central point of referral. For us here in Sarasota, it's our CBC, the Safe Children Coalition. If they are working with moms, pregnant moms who are using substances, then they can develop the plan of safe care at that point in time before the baby's even born. And that's a really effective mechanism. And that referral can really come from anybody. It can come from our Healthy Start coalition to our Healthy Families program, or from anyone who is working with the mom and is aware that she is using substances and that the baby has been prenatally exposed. So that plan of safe care can start very early and then it can continue and be built upon once the baby is born. So statute modification. States have a wide range of experiences implementing the CARA amendments to CAPTA, as specific child maltreatment statutes guide agency policies and procedures and strategies that states operationalize. And I've taken a look at a number of different states' ways of doing this, and some of them are quite different, but they all are making sure that they are carrying out the requirements of the CAPTA and the CARA. And they just have some states have different ways of doing that. And so it's important to know how we do that in the state of Florida. And you can know that through reading the CFOP. And since 2018, 28 states, including Florida, have described modifications to their state statutes in their annual progress and services report. And most of these modifications took place in 2017, following the passage of the CARA amendments to CAPTA. So for many states, statute modifications were an initial step toward achieving compliance with CARA. And the most common changes related to modifying the statutory definition of child maltreatment to include aspects of prenatal substance exposure. And prior to this, that was not present in most of the plans. And then changing the process for notifying CPS about infants identified as affected by prenatal substance abuse. So we're going to take a polling question right now, and my friend Rebecca is going to help me. And I want you to note in the poll which statement is not correct. The Child Abuse Prevention and Treatment Act, CAPTA Reauthorization 2010, and the Comprehensive Addiction and Recovery Act of 2016 makes several changes to CAPTA. One, it expands exposure criteria beyond illegal substances to include alcohol and prescribed medications. Two, it requires the plan of safe care to address the needs of both the infant and the affected family or caregiver. Three, development of policies and procedures to address the needs of infants identified as being affected by substance use withdrawal symptoms. Or four, requires healthcare providers involved in the delivery and care of substance-affected infants to notify the Child Protective Services system only if they believe the infant is in danger. So which one of those statements is not correct? And your poll is up, so please vote. Respond with your answer. And as we can see from our polling answer, the correct answer, a lot of people didn't answer, but the correct answer is D. They are required, healthcare providers are required to notify Child Protective Services under any condition, not only if they believe the infant is in danger. So those who answered with D are 100% correct. So thank you so much. Oh, I see a woo-hoo from Tamara. Good job. And thank you so much for participating in that poll. And thank you, Rebecca, for helping me collect those answers and getting that poll done. I think these polls are so cool. I just love it. I was saying to Rebecca yesterday, I think it's so neat that we're able to do this. Okay, we will move on with our objective 2, and that is according to the National Center on Substance Abuse and Child Welfare, and that's a long acronym, LCSW, pregnant women may not seek health care, early prenatal care, and substance use disorder to avoid a maltreatment report to CPS at the time of delivery. So there's a lot of fear among pregnant women that if they see a healthcare provider or get early prenatal care and a substance use disorder treatment, they are afraid that they're going to get reported to CPS at the time of delivery and that their baby's going to be removed. And we talked about this in the last webinar. And some states have modified their statutes to clarify identification, notification, and reporting, and to achieve broader engagement of other systems to meet the CARA amendments to CAPTA, including designating other systems beyond child welfare to develop a plan of safe care. And it is really important to the Department of Children and Families that families feel supported, that they feel that we are here to help them through these challenging times when they are using substances and they're pregnant, and for the time after their babies have been born, and they may be prenatally affected by the substance or alcohol use. And it is a supportive plan. The plans of safe care, it is not a punitive, in any way, a punitive mechanism for families. It is a supportive mechanism for families to let them know that we are here to help them and to keep them and their babies on a healthy trajectory. And some states have modified their statutes to clarify identification, notification, and reporting and achieve that broader engagement. And in the plans of safe care, which you'll see as we talk about, there are sometimes multiple providers that are a part of that plan of safe care and all working together in a very coordinated, integrated system to support the mom and the baby and the family members if necessary or needed, and making sure that all are together, working together in a unified, supportive way for the infant and the mother. So LCSW has found that a distinction between a report and notification to CPS can support parental engagement in services and increase provider engagement in the development of plans of safe care. In implementing these plans of safe care for infants and their families or caregivers not involved in the child welfare system through partnerships with community-based agencies can provide access to needed services and supports while preventing future child welfare involvement. And I can just tell you from our own experience here in Circuit 12, which is Sarasota, Manatee, and DeSoto, those families that have been working with Healthy Start or Healthy Families and have been referred and notified, CPS has been notified, and those plans of safe care have gone into place, that has greatly reduced the need for removal at the time of delivery and or future involvement with child welfare, which is exactly what we want to see. We want to see these families supported. We want to see the issues that are present with the mom or the issues that are present with the baby taken care of, and that all necessary services and supports are in place, and hopefully to prevent any more future substance exposed newborns by that mom, or certainly any continued substance use by the mom. So the difference between notification and report to Child Protective Services. So although CAPTA includes a requirement that healthcare providers involved in the delivery or care of infants born with and identified as being affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or a fetal alcohol spectrum disorder, notify the CPS system, it does not establish a definition under federal law of what constitutes child abuse or neglect. The ACYF program instruction from January 2017 notes that, quote, the focus of the provision is on identifying infants at risk due to prenatal substance exposure and on developing a plan to keep the infant safe and address the needs of the child and the needs of the caretakers. And further, the development of a plan of safe care is required whether or not the circumstances constitute child maltreatment under state law. Most states do not have a notification process separate from their reporting process for child abuse and neglect. And so this was really, I think, a challenge when some of these regulations and mandates came down. The states had to figure out the most effective route and had to make some definitions of some of these things of child abuse and neglect, and how a report was different from a notification. And what we have found is that states with a distinct notification pathway for infants not at risk of child abuse or neglect, but which still require a plan of state care, have achieved this in a variety of ways. It can be the healthcare provider makes the initial notification to CPS. The staff at the hotline refers the family to a contracted agency to develop and implement a plan of safe care. And in our communities, I said that's our Safe Children Coalition, which is our CBC. They receive the initial referral and then really primarily responsible for developing that plan of safe care with all of the other providers that might be involved with the family. And then program instruction from the January 2017 notes that the focus of the provision is on identifying those infants at risk due to prenatal substance exposure, and then developing that plan to keep the infant safe and address the needs of the child and the caretakers. And we're going to walk through a little bit later in the presentation what that plan of safe care might look like. And further, the development of a plan of safe care is required whether or not the circumstances constitute child maltreatment under state law. And I think we said that and we notified that, we talked about that just a little bit ago. So states have reported that stakeholder engagement has improved overall, and that's really important because we need all stakeholders involved in this. This is not a single service issue. There are multiple services and multiple stakeholders that need to be included in this plan of safe care, need to be at the table to be supporting and holding the family and the infant, again, to make sure that they stay on this healthy trajectory and that we have them wrapped around in services. It's really a wraparound service model approach. And that's including not just healthcare providers, which have been the ones that have been typically holding the basket here when notification and reporting pathways are clear. Lessons from states engaged with LCSW show that standardization and clarity, one, alleviate provider concerns about reporting infants and their families to CPS when they have not identified child maltreatment concerns, and two, mitigate potential negative consequences for the infant and family, such as removing the infant from the mother when there are no immediate safety concerns for the infant. And so it's that early catching. It's making sure that we are proactive instead of reactive to a situation, and we all know the potential negative consequences of infants that are prenatally exposed to substances. And especially when the mother is continuing to use or abuse substances. The risk level for both are very high, and the risk level for the infant being, not just the infant, sometimes older children that are in the home, being removed due to those safety concerns. So I love that these plans of safe care are so proactive and that they are supportive rather than punitive, and that they are effective. We have documentation and information that these plans of safe care are working, and they're being refined in our community. We have a process for the plan of safe care, but it's continually on a quarterly basis being reviewed by the community stakeholders, and a dialogue is taking place about what is working well, where are maybe some of the gaps that we haven't considered, or where are some of the needs that we don't have a service system in place for. We haven't identified a provider that might be able to do that specific work. And so it's continually being evaluated and improved upon, which is really wonderful. And families are having a part of, are heavily involved in saying, this is what's missing, or this is what I need, and it's not in the plan of safe care. And then looking at how we can make sure that that gap is filled. And so that making sure that in your communities, that is an ongoing sort of circular process and not a linear process, is an important aspect in making sure that these are our live plans of safe care that are being reviewed and improved upon as children and families continue to go down the road of recovery. And then CAPTA does not define or provide a list of diagnostic criteria for infants born with and identified as being affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or a fetal alcohol spectrum disorder. So states do have the flexibility to define this group, and the definition each state develops has implications for which infants and their families or caregivers receive a plan of safe care. And again, the CFOP, the Florida DCF CFOP, has really, I think, done a great job at spelling out some of these definitions and when these plans and notifications should be put into place. So definitions of infants affected by prenatal alcohol exposure. The definition of affected by influences both families and the multiple providers and agencies they interact with, including prenatal care providers, birthing hospital staff, public health nurses, child welfare agencies, and substance abuse treatment disorder providers. And each system provides a unique and important perspective. Healthcare really focuses on the physiological effects of exposure on the infant and the mother. Substance use disorder treatment focuses on the parental substance use and recovery. And child welfare really focuses on risk, safety, and child well-being. So each one of these systems really have their own very specific focus and intention in how they work with the infant or with the mother. But in this system of a plan of safe care, all are working together. They are all stakeholders, and they are all working together in how to define, how we're defining infants affected by substances or prenatal alcohol exposure, and then which system has a role in making sure that we are addressing all of the ways that that infant might be affected by the prenatal exposure. So definitions of infants affected by, states report that having a clear definition, again, of affected by offers an important starting point to determine which infants require a notification or a report to CPS and a plan of safe care to understand and resolve the health, the social, and the developmental needs of the infant and the affected family or caregiver. It is really looking at the whole of the system, of the whole of the child and the whole of the family or the caregiver, and not just siloing the different pieces and parts that generally are not coordinated. A lot of these systems do not talk to one another. They do their own piece, but it's not a coordinated plan of care. This requires that this is a coordinated plan of care among all of the participants that are working with and providing services to the child and to the caregiver or family. So state collaborative teams that developed definitions of affected by achieved consensus from stakeholders by including perspectives of representatives from these multiple systems, as well as from individuals with lived experience. And then bringing stakeholders together early and often helped increase cross-system buy-in of the final definitions while supporting implementation and practice changes. And here again in our community, this was a process that was really almost, I would say, 6 months to 9 months long, bringing all of these individuals together to be a part of and to have a voice. And certainly the families were there. Those individuals with lived experience were at the table and were huge contributors to what needed to be in the plan of safe care and what kind of supports they needed, and also what they felt was punitive, what were the systems they felt was punitive, so that those could absolutely be just talked about and the changes could be made within those systems, and how they were approaching and supporting or not supporting the infants and the parents that were involved. So objective 3, with this public health approach, plans of safe care can be perceived as supportive, which is what we definitely positively want to see, and not a punitive response that is preventative in nature, that is destigmatizing, and that is very strength-based. And again, if you read the CFOP, and I again encourage you to do that, you will see throughout that the emphasis on being strength-based, on being destigmatizing, and on being supportive and preventive. We want to make sure that all of our efforts and how we're working with these children and families, that we're preventing any future babies born that are prenatally substance exposed, and to make sure that we're helping the mothers recover and stay recovered, which is an important and awesome responsibility and takes a tremendous amount of work on the part of the mom and the family system to make sure that we're providing those supports is in the plans of safe care is critically important. And then again, that coordination of care works best when these plans of safe care are shared across all providers that are working with the family, and progress updates are regularly shared across systems. And again, I think that's, every community, every circuit, if you will have their own specific way of doing that. We have a timetable here in our circuit for how we meet on those plans of safe care, and making sure that they are staying fresh and that they're staying current and that they're staying really focused on what it is that it needs to be focused on, and adapting and making changes as necessary. So this type of information sharing requires signed family members' consent to release specified information and to specify the individuals or the entities entitled to the information. And that was a lot of discussion that took place early on in our stakeholders group about how do we do these consents. This is a voluntary process, and we have to make sure that we're getting consent to release to all of these different partners. And because the plan of safe care includes SUD treatment information and health information, all consents must adhere to the Health Insurance Portability and Accountability Act, or HIPAA, and 42 CFR Part 2, confidentiality of substance abuse disorder regulations. So making sure that all of those consents and releases were done in accordance with HIPAA and the confidentiality of substance abuse disorder regulations took some time, and making sure that parents, or that women and parents and families understood that their signing of these forms, and it has to be signed consent forms, what that really meant. And sometimes we just put a form in front of a parent and say, sign this form. This is so we can share information, but we really don't do enough explaining about this is what we're going to share is about you. It's confidential information, but we want you to understand that in sharing this information it is so that every provider who is involved in this plan of safe care knows what is being done, has the plan, has the updated information, has the progress update, and that is to support you. That is not to catch you doing something wrong. It is to support you to make sure that we are doing everything right. And some states and counties have developed implementation toolkits, and I encourage you to look at Minnesota's. I have listed that as a resource in the resource section. Minnesota has done a great job at implementing these toolkits. Other states have done it in a different kind of way, but the Minnesota toolkit is really excellent to address regional differences and support local jurisdictions on how to roll out plans of safe care. And the toolkits may include updated definitions along with a brief synopsis of the Comprehensive Addiction and Recovery Act, or CARA, amendments to CAPTA guidance language to support interpreting definitions. And if you remember back, CAPTA is continually amending. It seems like almost every single year there's amendment to the guidance language because we're learning. And as we learn, CAPTA is incorporating what we are learning or where there's greater clarification or guidance that is needed. And so it is that circular kind of always updating, always reviewing. And in some of these toolkits, that language is continually updated and reported. There's also, Minnesota has a plan of safe care template that's excellent. And there's also one in CFOP. And there are some other templates that you can pull offline that are really, really excellent templates. And then you have everything that you need right in front of you to ensure that as you're developing your plan of safe care, you have every single element that is required in the plan of safe care right there in front of you so that you're not forgetting to do anything. And the plans of safe care are very comprehensive and very detailed, and they take time to develop and also time to review and do progress reports on. So the guiding principles and policies for using and sharing the plans of safe care, information on the importance of prenatal screening and examples of screening tools, information on child welfare responses to notifications and reports. That is all included in the Minnesota toolkit, and I'm sure as well as other states' toolkits. So I think this is probably, it's 10:42, but this is probably a good point to take our 5-minute break, because now we're going to get into the detail of what the plans of safe care components look like. And we are actually moving pretty rapidly in our presentation today. So this is also a good point if you have any questions or comments to put them in the chat, and we can take a look at that after we come back from our break and see if we have any questions that we might be able to answer or look at any of your comments. So let's just take a minute or two, that if you want to put anything in the chat, go ahead and do that. Somebody asked when we get to the resources page, all of those links that I just talked about with the Minnesota Toolkit is there, and some other additional very valuable resources will be on that link. You're welcome, Ashley. So any other questions you have, please put in the chat. And it is 10:43. So I'm going to ask my friend Rebecca to put up our break slide, and we will come back at, well, why don't we say 11? That you'll get an extra 2 minutes. So exactly at 11 o'clock, we will return and we will continue with our presentation for today. Take a nice break, get something to drink, stretch at those muscles. You've been sitting for an hour, and we shall return.
everyone. Welcome back to today's webinar. Ms. Shea, if you are ready, I will go ahead and turn the presentation back over to you.
Thank you, Rebecca, and I am ready, and I hope that that was a good, quick little break for you. And we are going to resume our presentation, and we're really going to dig into the detail of plans of safe care and what these components look like. So the first aspect of the plan of safe care is the plan of care for the infants components. So we're going to take a look at what that looks like. And so we're going to look at the prenatal exposure, and the elements or the questions we're going to ask ourselves in doing that are, did the infant test positive at the time of birth? Was the infant symptomatic or asymptomatic or withdrawal symptoms? We're going to describe the pharmacological and non-pharmacological interventions. And then in hospital care, was the infant diagnosed with neonatal abstinence syndrome or fetal alcohol spectrum disorder? If yes, what was the infant's length of stay in the hospital or in the NICU? And then we're going to look at other medical or developmental needs. What other medical concerns have been identified for the infant? Are there any developmental issues which may require follow-up screening? And then we're going to look at pediatric care follow-up. When is the next scheduled well baby checkup? And does the infant require any specialized screenings or treatments at this time? And then referrals for early intervention. All infants suspected of being affected by substance exposure should be referred to a home visiting program for follow-up. Program selected and assigned the worker, and what is the date of the first home visit? And that can be Healthy Start, that can be Healthy Families, and those are probably the two most primary ones that are used. And then we're going to take a look at the plan of safe care of the mother for the mother's components. And we're going to look at substance abuse history, substance use and mental health, and substance use history. We're going to identify all substances used in the past, legal and illegal. We're going to identify current use pattern, legal and illegal, the mother's age when she first began to use each substance, and then the mental health history. Has the mother been Baker-acted in the past? Has the mother been clinically diagnosed with a mental health disorder? Is there unresolved trauma in the mother's life? And then we're going to look at treatment history. The discharge status from the last program attended. Has the individual been involved in ongoing recovery work since discharge? Does the mother need to be re-engaged or engaged in treatment? And then we're going to look at medication-assisted treatment, or MAT. The assessment of the mother's compliance with MAT during pregnancy. We're going to look at current medication, dosage, and dispensing schedule. And then, is MAT supported by cognitive behavioral therapy, group work, and peer support? And then we're going to assess the mother's past and current history and indicate the need for the following: what treatment services need to be provided and initiated, by whom, and at what point, and we're going to do that in priority. And then address and identify and address any challenges or barriers to service initiation. And then we're going to describe the mother's medical treatment as well, and her medical history. And we're going to look at the mother's participation in receiving prenatal care and results of prenatal drug screening. We're going to look at pregnancy history. Did the mother experience or has had a history of pregnancy complications? And we're going to look at other ongoing medical issues that might require follow-up or additional treatment. And screening and education. Is the mother planning on breastfeeding the infant? Has the mother considered medical planning options? Has the mother considered family planning options? And then OBGYN, the date and the purpose for the mother's next scheduled follow-up visit. And then referrals for any unmet healthcare needs, indicates the following unresolved or ongoing issues that need to be addressed, again, in priority, by whom, and addressing all of the challenges and the barriers to service initiation. And we just covered that. The mother's the medical component. And then the plan of care for the family component. And what I love about this is that it's really looking again at that entire family system. It's not just about the baby. It's not just about the mom, but it's about the entire family system. Because if we don't look at all of that in unison, then we're really risking an opportunity where things will fall apart, because all of this is so critical. And keeping that watchful eye, again, of support, and helping that parent to feel that they can trust the system that is supporting them, and to eliminate that fear that they've had that their child might be removed, to really know that we're working with them to make sure that doesn't happen, and that their child is healthy, and that they are healthy. So in terms of the family components, we're going to look at child welfare involvement. We're going to discuss prior reports involving substance misuse allegations. And has any child in the home previously been adjudicated dependent? And the risk level. What is the basis for the assessed risk level? And then really noting that any safety concern should be reported immediately to the child abuse hotline. And we're going to look at the parent-child relationship, using behaviorally specific observations, describe the caregiver and the child dynamics, assess the need for parenting interventions like early childhood court if the child has been removed and is in the child welfare system. Child-parent psychotherapy is an incredibly important, I believe, intervention for all of these prenatally exposed babies and their parents. In the last presentation, we talked about the risk of having a prenatally exposed infant and all of the issues that child might come with, a struggling mom who is trying to remain clean, going to treatment, and all of the many challenges that can take place in that relationship that really needs to be a solid relationship. In both child-parent psychotherapy and circle of security are two critical interventions that I think can strongly support that parent-child relationship. Assess the need for parenting interventions, and then typically skill-based for older children and attachment-based for infants and very young children. And it's not just the baby that we're going to be talking about in this parent-child relationship, but all of the children in the home. What do they need? What kind of treatment or therapy can we support the relationship that the parents are having with that child? And then living arrangements. We're going to identify all household members and caregivers, if any. The support network. What is the level of the support for family? What kind of extended family members do they have that are supportive? What kind of neighbors do they have that could be supportive? What kind of church members might be supportive? And one of the things I think we all know are that the families that tend to do the best are those with strong support networks. And the plan of care team can actually be a support network to the family, and should be a support network to the family. And I know that in our early childhood court system model, which I probably won't have any time to get into today, but the parents that have been involved in that particular early childhood court system, and remember, these are babies that have been removed, young children, birth to 3, and in some systems birth to 5, who have been removed, are in foster care, and the parents are working on getting the child back. And those meetings that are taking place are very supportive in the family. The judge is incredibly supportive to the family. And again, getting away from that that, that trauma question of what's wrong with you and asking what's happened to you, and reframing for the family that they're not bad, they're not horrible, bad things happen to them, and that we're here to help them raise their children in a healthy manner, to break the cycle, which has probably been multi-generational, and to see, to reduce their fear, and instead to develop trust with the systems that are that they are working with. And then current services, really identifying all services and some community supports that are currently in place, and then all services that need to be initiated to add support or to address unmet needs. And that can be done by the program or the worker. And I remember sitting in on one early childhood court meeting specifically, and both parents were there, and they really said they had no support system, and they had no faith-based community. And one of a worker that came with a mom from another program said, "We have a really strong support system at our church to help families just like you. And would you be interested in that?" And got that family connected, and that church became, that faith-based community became one of the strongest support system for that family. So really, having everybody be a part of the solution as to what potential ideas or solutions or connections might take place that can really help these families build that support system. I can't emphasize enough that family support system, that the importance of that. It can really make or break whether these are successful or not. So just being mindful that there might be different ways of incorporating or bringing more people to the table to support the family. And then the mother's plan of care components, we've talked about this, the OBGYN, the referrals in terms of medical care, for other additional unmet health needs. It needs to indicate the following unresolved ongoing issues that need to be addressed, again in order of priority, and identifying and addressing the challenges and the barriers to service initiation. And plan responsive, family-centered plans of safe care. And let me just say one more thing. Once that plan of care is fully developed and all of those elements are filled in and everybody is on board, the entire team is on board with that plan, the parents sign off on this. The parents and the worker, whoever the worker might be that's responsible for developing the plan of safe care. And I want to read to you what they are signing. This is the closing statement. The goal of a plan of safe care is to ensure that you, your child, and your family receive the services necessary to advance personal and family recovery and resiliency. Our goal is to accomplish this by building on the strengths that you have as an individual, family, and within your community, so that together we can reduce the risk associated to infants who may have been affected by prenatal exposure to alcohol or drugs. Your participation in a plan of safe care is voluntary and in keeping with 39.01 1B Florida statute. We strive to work with you in a constructive, supportive, and non-adversarial manner to provide you with the best prevention and intervention strategies to accomplish our mutual goals. And then the parent or parents and the worker sign and date the plan of safe care. I love this closing. Very detailed what this is about. It is so strengths-based and so supportive in nature. And just imagine being a parent that has probably had a lot of negative experiences with service providers, and certainly with child protective services, if they've been involved in that. This is a whole different way of framing and reframing for the family the values and acknowledging the strengths that they do have, because everybody has strengths. and having them be able to see that they have strains is really, really important. So again, the worker signs and dates the plan of safe care, which I just read. The goal emphasizes on building the strengths they have as an individual and family, and again, emphasize that it is voluntary and that we strive to work with you in a supportive, constructive, and non-adversarial manner. And I really encourage workers, and I think it's happening everywhere anyway, to read this out loud, not just to, say sign here and, this is the plan of safe care, sign here, which we often do, but to really read this with the family and to ask them if they understand what it is that they're signing. And so that they have ownership, and they have to have ownership. And this is creating that sense of ownership for them. And that can be very, very empowering for families, for individual, for moms and dads, and for families. So we really are way ahead of our time. So I'm just going to take a moment to talk about referral criteria. And we have a pretty comprehensive plan of safe care in our circuit 12, that I talked about, that is really took quite a while to develop. And it specifically states that the plan of safe care is to identify pregnant people with substance use prenatally, connect them with resources, and provide ongoing coordination and support prior to and after the delivery of their baby. And by linking mothers and families and babies to services in the community, we can reduce the risk of child removal and child welfare involvement and improve child and family health and well-being. The plan of safe care differs from a safety plan, which we talked about in the beginning, but it's really important to remember that they are totally different. The safety plan is developed by DCF once child welfare is involved after the baby is born. And some of the referral criteria, and again, anyone can make a referral to whoever is the hub in your community. The hub in our community is the Safe Children Coalition, and those referrals can come from anyone, and the referral criteria can be any pregnant individual with a history or current illegal, legal, or prescribed substance use, and that includes methadone, alcohol, marijuana, opioids, etc., that want help. And again, this is a voluntary program, and it is parents struggling with substance use with a child under the age of 2 years. And then after delivery of the baby, or when children are present, a call to DCF is required. This does not take the place of that requirement. DCF will then start a plan if the family does not have one. So every community probably has their own referral process. That's included in our plan of safe care and what that process is about. And again, I encourage you to look at what your community has, how you're working on that as you're in your own individual community. And again, go back and look at that CFOP and make sure that you have all of the elements that you need in your plan of safe care. So let me just see if there's anything in the chat. So someone has said plans of safe care was in place 14 years ago when I was a child protective investigator. My first case was a death baby case of a mother who had 5 previous kids removed and parental rights taken away of all 5 children. The child, only 4 months old, died in her custody. Case closed, mother not charged in this case. And then if it wasn't, I wonder if this situation could have turned out differently had the plan of safe care been in place. And that's a good wonder. And that's exactly why we are doing this, is to make sure that these kinds of horrible things that happen do not happen. And that is, again, making sure that we are wrapping ourselves around this baby and this family and making sure that they are safe. And then if I can share, I just want to say, as a mom who has had a substance exposed newborn because I was too afraid to speak up about my substance use, that makes my heart so happy to see and know that we are doing this. And then from Sherry, how would I locate these hubs in our community? I would start with calling your Safe Children Coalition. Again, the hub can be anyone, but if you start with your Safe Children Coalition, they'll be able to, I don't mean Safe Children Coalition, that's what we call our CBC here, but if you call your CBC, they'll be able to direct you to where the hub is. And then someone from Mike, sorry, I have to leave. I'm playing Santa for the IDD participants at my agency. Happy holidays. Well, Mike, thank you for joining for as long as you could. I'm sure you're going to make a wonderful Santa. And let me see if there's any more. I just wanted to say that I love the wraparound model and working with our parents, not against them. They need supportive people in their lives, and I think more of us need to remember that. Absolutely, Stephanie. That's a really good comment. Did I miss any other comments, Rebecca, that you can see?
No, you did not.
Okay, good. Well, thank you for all of those comments. That's really good to hear from all of you. And someone said, completely concur with Stephanie. Good. Yes, the wraparound process and supporting parents is the way we change the system. And I think it's going to go a long way in helping to break these cycles, these multi-generational cycles that we see of substance use and abuse and child abuse, and all of those cycles that we just want to end. I mean, we want healthy children and healthy families, and I think this is an incredibly important way to help do that. And then I was interested hearing the support provided by the local faith-based group provided. Yes, that was just an amazing meeting. I'll never forget that. And that's where we hear think outside the box so much. But at that table, when you see that, there's a barrier or there is a problem, and I really hone in on if that family does not have a support system, they are at higher risk than families who do have a support system, and really reaching out. And I remember one mom saying, the only support I have is from my grandmother. My parents are not supportive to me. They're very negative and punitive with me. And so we brought grandma in, and grandma had friends. So grandma brought her friends, and this mom then got a very strong support system from her grandma and her grandma's friends. So it's like really, thinking about, just tell me one person who supports you, and then we can, sort of go from there and see how we build on that. And then certainly making sure that we are support people ourselves to this family. And then someone said, where can someone find where parenting courses are being held? In our community, we have a hub of where, and actually 211 also has this, of where parenting courses are being taught. And you can go online in your community and find out what organizations are teaching parenting classes. We actually have Healthy Start in our community. The Florida Center teaches parenting classes. We have a Parenting Matters program. So we have a number of programs in our Sarasota, Manatee, not as much in DeSoto community that are providing parenting courses. And then thanks, good presentation. Oh, thank you so much. So, and someone said, I believe the COS website has a list of providers. I think that is right. 211 Brevard is a great resource for us in this county, and 211 has become a great resource, I think, in many communities for seeing what's available in your community. And then Vicki said, remembering to be strength-based can be challenging. With positive support comes strength, absolutely positively. And then someone said, Bernadette said, Aunt Bertha offers lists in different areas, cities of the county. I don't even know about Aunt Bertha, so thank you for sharing that. And then I'm glad that this has been an informative and clear and concise presentation. I hope it hasn't been too dry for you, but it's just such important information that we all need to know. and the takeaways for each of us is really important, because everything that we can learn to help support our children and our families is going to go a long, long way to having healthier communities and a healthier world. So thank you. And we are now going to watch a video that I love. It is Linking Mothers and Babies to Services. This is by the Florida Perinatal Quality Collaborative, and it stars one of my very good friends, Dixie Mortiz. And Rebecca, if you can get our video going, I totally appreciate you.
Hey, Kathryn, are you ready to finish up? Okay, everyone. I think that we have Kathryn is unable to come off of mute at this time. Let me see if I can't try and get her back. Give me just a moment. Thank you. Okay, everyone, it appears that we have lost Kathryn, and we were at the end, so I am going to go ahead and just click through the rest of her slides that she has. We were at the end. This is all of the resources, and this will be sent to you as well. I have posted it in the chat. And so we will post her information so that you can contact her with any further questions as well. So give me just a moment and I will get the evaluation posted in the chat panel for everyone and begin our closeout.
Can you hear me, Rebecca?
Oh, yay, you're back. Yes, okay, I just told everyone.
I think it was because I said you didn't like what I said about WebEx and it just went completely berserko and I lost it and I had to come back in. So sorry about that, folks.
No, that's no problem. I actually had just kind of told everyone that we were at the end and let everyone go click through the resource slides for you, and we were just closing out. So I'll let you go ahead and take over, and then I'll finish close up.
All right, sounds good. Are you gonna? Okay, great. Okay, super. So what I had said before I got kicked out is that if you could just take a moment in the chat, because we do have some time, I'm really curious to know what you thought about the role play between Dixie and the pregnant mom. What did you see? What did you like that Dixie did that really helped to engage the mom or help the mom feel more comfortable? What was new? What did you really like about that role play? If just, I liked her use of strengths. Yes. Making her feel safe. Thank you for that. Yes. Yes. She definitely did not come off negative at all. You're right. Very supportive. She wasn't judgmental. The positive reinforcement. And did you hear Mom say, I didn't expect to feel like this today. I didn't expect you were going to be nice. Isn't that just so telling? Gave her a bus pass. Yes. Supported her. Asked permission. Yes. Oh, you guys are putting so many great things in here. Effective listening, supportive, the level of validation. Yes. And just stay positive. Yep. Focused on mom's strengths, her entire attitude. And I loved how she kind of leaned into her, even physically kind of leaned in. And And that says a lot. Your body language says a lot, your tone of voice. She was smiling the entire time. And yes, because the mom expected judgment and condemnation, right? So that compassionate attitude, compassion is such an important word in all that we do, but especially in these situations. The good use of motivational interviewing, yes, and open-ended questions to get mom to express herself. And listening, she really listened and valued. And, you know, when mom said, well, sometimes I sleep in my car, you didn't see Dixie go, oh my God, you know, you can't do that. She was just like, okay, you know, let's see what we can do about that. Here's what needs to go into the plan. Great eye contact. And yes, she asked the mom what she wanted, which is, and assisted the mom in seeing the opportunity for a different future than she had imagined. So really great comments here. Thank you so much for that. I agree. I think it's just a great video. So we really are coming to the close. I'm going to actually be giving you guys back some time this morning. I know everybody needs time, but any additional questions that you might have before we kind of end our presentation? And I see that you have the link in your chat to the evaluation, which is very important because that helps FATA and it helps me and it helps DCF with knowing what to maybe present in the future, but also how we can do these presentations better. So let me, and also please, if you have questions as we go, you know, maybe you leave the presentation today, you run into a situation. Somebody said my agency blocks the evaluation. I hope that doesn't happen. If you have questions down the road or you're not sure about something, please, you will have my contact information. Please do not hesitate to reach out to me through email or on my cell. And I promise you, I will, if I don't know the answer, I will get you the answer. Because as Dixie said, we are not alone in this. We are all in this together to learn from one another and to make this a better world for our children and our families. So many thanks to you for taking the time to be here today. I know it's holiday time and there's a lot going on, and so I appreciate you being here. Thank you, Rebecca and Eric, my team. That's been fantastic and wonderful and helps me get through all critical situations that might arise. Very grateful to you, very grateful to FATA and to DCF for allowing me to present this presentation to you today because I have great passion for doing this work, and I want to help to make the world a better place for our children and our families. And you do have a list of references, and I've included a lot of references here for you with the links, so you can dig deeper if you want to look at, you know, more specific information. And I have those references broken out by the slide, so that'll make it a little bit easier for you. The Florida Center for Child Welfare, I really encourage you to go and look at that as well. It's a great resource. And the video is there. And then again, my contact information and my email is there, my phone number is there, and please don't hesitate to reach out if I can do anything. And I guess, Rebecca, at this point, I will turn it back to you. I wish all of you very happy holidays, and I hope to see you again in future trainings.
Well, thank you so much, Kathryn. We have included Kathryn's contact information so that you may contact her with any further questions. Kathryn, we really thank you for all the work you put into this webinar and all the valuable information you shared today and working with us through some technical difficulties. And a couple of items of business before we conclude. Please see the chat panel for today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FATA's website. If you want to receive CEs or statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. You will have to sign in or create an account in order to take the evaluations. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number when you register. After you register or sign in, you will be directed onward to the evaluation. You will need to use the same email address you used when you registered for the webinars through our WebEx link than when you set up your profile in VADA system. This is the only way to connect your attendance to your profile. You will get a second opportunity to complete the evaluation later today through a follow-up email from messenger@webex.com. Please note that the evaluation will close Wednesday, December 15th. We will not email statements of credit. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after this webinar concludes. Thank you for participating in today's webinar. We'd really like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Please have a great rest of your day. Thank you.
Rebecca and Eric, if you're still there, thank you so much. And I'm happy I was able to go out and get back in pretty quickly. So wonderful holidays to you.
Thank you. You as well, Kathryn.
Thank you so much. Stay healthy and well.
You as well.
Okay, bye-bye.